Time for some clinical peanuts.
The patient named XYZ, aged 45 years, whose gender was male. He was a resident of India. His chief complaint or presenting complaint was double vision from about last 1 week. My patient's question was all right. 1 week back, when he started having a complaint of double vision, which was gradual in onset, progressive in nature. It was associated with pain in neck, which was aggravated upon exertion and relieved after resting. He has no other significant complaint. He's a non-smoker and non-alcoholic. He has no significant medical history, no comorbids, no history of any surgery, no any history of any systemic drug intake. As far as ocular history is concerned, is myopic and presbyopic. He has using glasses. Otherwise, he has no history of using. Continue.
No, just wait. Don't start your examination. Come back to your history. We'll discuss the history a little bit.
Right, sir.
Okay. So, can anyone just tell me, like, what is the basic complaint that the patient has come with? So, we know he's a 45-year-old gentleman who is a resident of India, and he has come with a complaint of double vision since the last 1 week, right? What else do you want to elaborate on this? So, what is the first thing that comes to your mind? Okay, a patient 45-year-old male is coming to you with diplopia or double vision. So what is the first thing that comes to your mind? What is the next thing you want to do in your history?
So first we'll ask whether it's a uniocular or binocular diplopia.
Right. Very good. So correct. Who was Dr. Shruti? Yeah, right. That's correct. Whether the diplopia is uniocular or it is monoocular diplopia or it is a binocular diplopia. So now we know that this patient has a binocular diplopia. So what is the next thing that you want to do? You can be free, just answer it. It's okay even if you're wrong.
So diurnal variation, sir.
Diurnal variation is okay, valid point. I will still, okay. Diurnal variation is another good point. Okay. Anything else you want to ask?
Whether the diplopia is for far vision or near vision.
Okay. What else?
Any restriction in the extraocular movement?
That's fine. That will come in your examination. More than deviation, the simplest thing is whether it is a crossed diplopia or an uncrossed diplopia. That is what you're supposed to ask. Okay. The simple way of how you can ask in the history is whether the patient is seeing what is the distance between the two objects that he's seeing, or the same object, what he's seeing double, what is the distance, and whether it is a vertical diplopia or a horizontal diplopia. That is another thing that you're supposed to ask. That changes your entire thought process. Correct? So whether it is a vertical diplopia or a horizontal diplopia is something that a patient may not be able to tell you. Only a few patients may be able to tell you if they are very observant or something. But generally, a horizontal or a vertical diplopia is something that is more important that I was coming to. That is something that the patient will definitely be able to tell you. The easiest way is you ask him to show two fingers, and whether it is this way, or this way. This is how you're supposed to ask him to describe. So that is the simplest way to do it. Okay. So these are some extra points that should be added in your history.
I would like to know
So
more
now,
about how to ask him about crossed and uncrossed diplopia. That is not clear in the mind yet.
Right. Crossed and uncrossed diplopia, like I said, your patient has to be very observant. Only then he will be able to tell you whether it is a crossed or an uncrossed diplopia. It is more of an examination finding. Very rarely that the patient will be able to tell you. But more than that, what I meant to say was whether it is a vertical or a horizontal diplopia, that is more important. Or whether it's a torsional diplopia, that is the third type of diplopia that you may get to see. So that is more important. Okay.
Yes.
Your thought process or in which direction you're supposed to go. Because, yeah. So go ahead with your examination. We'll discuss further.
Right, sir. So on examination of the right eye, the visual uncorrected visual acuity was 6/12. His corrected visual acuity was 6%. His near vision was N6. RAPD was negative. Pupil was round, regular, and reactive. His extraocular movements were full in all quadrants in his right eye. His cornea was clear. AC was formed and quiet. Lens was phakic. Vitreous was quiet. Cup to disc ratio was point. And rest of the retinal examination was unremarkable. On examination of his left eye, his corrected visual acuity was 6/80. Corrected visual acuity was 6%. His near vision was unsteady. The RAPD was negative. Pupil was round, regular, and reactive. His extraocular movement was restricted on adduction. His cornea was clear. His AC was formed and quiet. Lens was phakic. Vitreous was quiet. Up to disc ratio was 0.3. Size moderate. His elevation was good. His Bell's reflex was good, which was negative. His Marcus gun jaw was negative. Rest of the examination points were unavailable. So this is the picture of the patient. One is on adduction when the patient was asked to look towards the right. Another was when the patient was asked to look down. Sorry, up. And let me play the video. When the patient was asked to elevate, depressed, depression was normal. This is in the primary position of gaze. This was towards the left gaze, and this was towards on abduction, or when the patient was asked to look towards the right.
So come back to your eye examination column, the two columns that you had, the slide that you had prepared for examination, the first slide of your examination. Okay, so what is something that is extremely important that is not well documented in this slide? Whenever you're talking of third nerve palsy.
Yes, sir.
So it is, what was the size of the pupil in an undilated state?
Sir, the pupil was round, regular, and reactive, and it was not involved.
Was there an anisocoria?
No, sir. It was the size of the pupil was comparable to the fellow eye.
Okay. Okay, that's okay. So coming back to basics, when do you consider anisocoria to be pathological and what is physiological anisocoria? Up to how much difference is acceptable?
Up to 2
2
mm.
Correct. It's up to 2 mm. So a difference of around up to 2 mm is acceptable. Beyond 2 mm and above is considered to be pathological anisocoria. Okay.
Right, sir.
So we have a 45-year-old gentleman who has no systemic comorbidities and he is complaining of diplopia since the last 1 week with ptosis in the left eye and adduction limitation in the left eye. Pupil is
Right.
round, regular, and reacting
Reactive.
in both eyes. Okay. So, what is your provisional diagnosis or what is your differential diagnosis now? Or is there any more tests that you want to do?
Sir, in case of ocular examination, I would like to check the, as you previously mentioned, sir, vertical or horizontal diplopia.
Okay, fine. Let us assume he has a horizontal diplopia. It's a cross diplopia, like how it happens in a typical XT case.
Right, sir.
What else do you want to do now?
Nothing comes from
Maddox
my
slot test. Okay, that will just tell you again the type of diplopia. So that is whether diplopia is there or no. Okay, that is fine. He has diplopia. You know that the patient. You can do a simple diplopia charting using your red-green glasses and this streak retinoscope. That will also tell you what type of diplopia that is. Not really. Patient has diplopia means binocularity is good. So you're not going to get any extra information with stereopsis. Like they mentioned, like it was discussed earlier, you have to rule out myasthenia in this case. Okay, I will have a strong suspicion for myasthenia also. Ptosis measurements, okay, that will just tell you the degree of ptosis, whatever. Clinically, on looking at the photograph, you know he has a clear-cut ptosis. Okay, so yeah, wait, we'll just come to the imaging aspect. Ice pack test, yes, correct, absolutely. That is something that I want to do in the clinic because you have to go from cheaper tests to slightly expensive tests because you have to think of the patient. Okay, so whatever is your clinical examination, the clinical test that you can do in your office, you are supposed to do that first. So ice pack test is definitely something that I want to do because I want to rule out myasthenia in this patient. Okay. Fatigue test, okay, you're doing ice pack, which is slightly better test. If ice pack test and fatigue test both come out to be positive, you schedule for a neostigmine test and you see what is the response to neostigmine test. Edrophonium, Bell's phenomena, okay. Bell's phenomena will be affected if it is a third nerve palsy, definitely. And okay, we assume that it is a third nerve palsy now. Okay. So now when you're proceeding for a third nerve palsy, what are the battery of investigations that you want to go ahead with? Somebody mentioned MRI in the chats. Who mentioned MRI? Yeah, Ruchi Barot. Dr. Ruchi, could you please unmute? Okay. So, cranial nerve palsy, there are two approaches, and certain physicians have different schools of thoughts for this. Generally, a pupil sparing third nerve palsy is a medical condition. Okay. It generally does not warrant any neuroimaging or it does not warrant any surgical intervention as such. But in this particular patient, since he is 45 years old, I would personally image the patient. Okay. Had this same situation been in a 65-year-old male, I would not have imaged him. You're getting my point. So the main decision factor or the main, rather the clinical test that I want to see where I decide what is the next imaging or the investigative modality, that is the pupillary reaction. In a pupil spared condition where there is pupil sparing third nerve palsy, but there are certain exceptions for imaging or there are certain indications for imaging rather. So in this patient, because of the young age, I would like to image this patient once. Okay. So can anyone just chip in and say that what is the specific instruction that you want to give to your radiologist, or what is the thing that you want your radiologist to specifically look for in this case?
Some myelination, periventricular myelination. It will rule out MS.
No, orbital.
Okay.
And sir, aneurysm.
Okay, let's go back slightly more to our basics. we have to know what is the course of the third nerve for that. Okay. So I'm assuming that all of us know what is the course of the third nerve. So generally in third nerve palsy, the lesions can generally be at the nuclear level, that is at the midbrain. If it's the infranuclear palsy, it could be at the midbrain or at the junction of the posterior cerebral artery, or at the junction where the nerve is the cavernous sinus, or in the cavernous sinus or the orbital apex. These are the most common areas where the lesion can be. Okay. So ideally in any cranial nerve palsy, you have to do a complete neurological examination. Okay, just a gross neurological examination, which we have learnt in our MBBS days. Look for power. Yeah, I'm sorry. I think I lost connection in between. Yeah, am I audible?
Yes, sir.
Yeah. So, you're supposed to do a complete neurological examination where you're supposed to look for power, sensations. You have to examine all cranial nerves. Okay, because you have to rule out polyneuropathy involvement or multiple cranial nerves involvement. Your entire decision making changes. So that is another very important thing which we have to examine in all cases of any cranial nerve palsy, for that matter. Okay, a complete, I suppose we all know how to examine cranial nerves. So a gross examination of all cranial nerves and the gross motor examination and sensory examination is to be done, including the gait. Okay, because there are certain syndromes like Weber syndrome and other syndromes that are associated with third nerve palsy that could be present coexistently with the patient. Not saying it's present in this case, but particularly in a case with third nerve palsy, examining all cranial nerves and a gross neurological examination is important. Okay. So, right. In this patient, I would personally go ahead with an MRI brain. What I would request the radiologist is to trace third nerve palsy using a sequence called as the CISS sequence. That is something what the radiologists use to trace cranial nerves. So they trace the entire path of the cranial nerve, usually in this case, the cranial nerve third on both the sides, which will include images at the stem level, at the midbrain level, at the colliculus level, as well as the cavernous sinus.
और नौ पालसी पे तो मैसेज डाला हुआ है स्टार्ट
That is a specific instruction that I would request our radiologist. MRI, please remember, in any cranial nerve palsy, or for that matter, in most of the neurological or neuro-ophthalmological conditions, MRI has to be with contrast. Please do not advise without contrast. Okay. It may be little heavy on the patient's pocket, but you do not, the extra information that you get with a post-contrast scan, such as enhancement in the cavernous sinus or at the orbital apex, those situations can be easily missed without contrast. So your entire diagnosis will change. That is why please advise MRI brain orbit with contrast, with CISS sequence. That is the entire thing that I would write to the radiologist. Plus, write in short about the clinical history of the patient so that your radiologist knows. See, your radiologist has not seen the patient. He does not know what to examine or what to look for in the report. If you write a specific brief note, he knows exactly what to look for. That is an important thing that we all have to remember. Okay, no plain MRIs to be done. Please always get it done with a post-contrast scan done. If there are situations where you cannot get a post-contrast scan done, as for example, like a kidney patient or a renal failure patient and all those situations, in that situations, please advise flare sequencing. So that is something that you're supposed to specifically write to your radiologist. The other thing, what someone mentioned is to rule out diabetes, hypertension. Yes, we have to do that. A complete ischemic profile has to be done, which will include our lipid profile. CBC, ESR, CRP is another thing that I would like to do to rule out any inflammatory conditions. Besides that, I would like to do serum homocysteine levels, because in a young patient, serum homocysteine has to be examined if you are suspecting an ischemic cause or an ischemic palsy. Okay. Other than this, I would also like to do if everything of this is normal and the MRI is also normal, plus the patient is not in myasthenia, I would again take the decision based on CRP and ESR. I would also want to rule out vasculitis, ophthalmoplegic migraine, which will be my second line of diagnosis or the second thought process that I will be having. I hope you all understood.
Yes, sir.
So, specifically, any other doubts related to this case? Anyone wants to ask?
So you said that because he's a relatively young patient, you would go for imaging directly. Rather, it be an older patient, you would have gone. You would not have gone
If it
for
would have
imaging.
been an older patient, say a 60+ patient, I would have gone for a prothrombotic profile and a diabetic and ischemic. I would rule out hypertension. I would rule out diabetes. I would rule out any other ischemic risk factors like homocysteine and lipid profile first. If mandatory, go in this condition. If everything is normal, then I would go in for imaging in an elderly patient. But since he is a young patient, I would image the patient.
So I would like to rephrase the investigations.
Right.
So you would start with MRI brain. You would like to know specifically the course of whole third nerve.
Right.
You would go for plasma homocysteine level.
Right.
You would go for CRP, then ESR.
A complete blood count, CRP, ESR, homocysteine, lipid profile. These are the 5 mandate investigations that I will do for, plus an MRI. Everything I will ask the patient to get and come for follow-up next week. These are the first line investigations that I will do. And of course, check the BP of the patient. And that goes without saying that you have to do it in your office. Check the BP of the patient.
So, Dr. Vishwesh, would you order a specific MRA also, or just
in a pupil sparing? No, Dr. Anuj, I wouldn't.
okay? Not so, if you follow up,
if there is even if there would have been anisocoria, I would have done an MRI. But if there is no anisocoria, then I don't think an MRA will help in that case.
So, as a routine, just a MRI would be. That is what you are saying.
An MRI, it has to be something related to the apex or the cavernous sinus only. Or a few cases of ophthalmoplegic migraine also I have seen presenting as third nerve palsy.
Okay.
Also ask for history of any precipitating event. That is something I forgot to discuss when we were discussing history. Any precipitating event like a seizure, high fever, or trauma. That is the most important thing that we have to ask. These are the things that you have to rule out. Traumatic third nerve palsy is a different entity altogether. There is no role of imaging in traumatic third nerve palsy. Please do not image the patient, even if it is pupil involving. Don't image the patient in traumatic third nerve palsy. You will just make the patient spend money unnecessarily. So, traumatic third nerve palsy is the only pupil involving third nerve palsy where you don't image the patient.
Why?
Sorry?
Why?
Because where is the lesion in traumatic nerve palsy? You should know. For that, you should know the pathway. If you read your Walsh and Hoyt, it clearly mentions that the lesion is at the entry of the cavernous, where the nerve enters the cavernous sinus in the posterior fossa. That is the exact site of lesion in case of a traumatic third nerve palsy. So it is not because of a compression. You are imaging just to rule out compression. So you know where the lesion is. There is no role of imaging. That is the reason. This is where you apply your anatomical knowledge to your clinics. And that is how you save an investigative modality. It is something like traumatic optic neuropathy. You don't image in traumatic optic neuropathy. There is no role of imaging in traumatic optic neuropathy, right? It's a clinical diagnosis. There is no use getting a CT scan or MRI in that situation. So traumatic third nerve palsy, I would not image. I would not image the patient. But yes, trauma has to be ruled out in your history. That is, it has to be your first line in your history. There was no history of trauma. Unlikely. Third nerve palsy because of that is usually not the case. Sixth nerve, yes, you can get, but not third nerve. Sixth nerve generally is more affected in raised ICP and all those conditions. Third nerve, not very much. Sixth nerve, because of its complex lines and the way it turns into the Dorellos canal, that is the most common site for compression. So there, yes, sixth nerve can be affected, but not really third nerve because of an hematoma. I don't think third nerve is that affected. So your clinical important. INO, INO cannot be. INO is a different entity altogether. What is the hallmark thing that you will get in INO is an abducting nystagmus. That is something that you will get in your INO. INO is completely different. It will not be related to this. I mean, this presentation is a typical third nerve presentation. So
because few of the members they had mentioned this as suspecting INO, so I thought
unlikely.
you can just.
If your ductions are fine, I mean, the other eye looked completely okay. INO, I don't think this. Yeah, but this is definitely a third nerve palsy, but we have to find out the cause of the third nerve palsy. That is very important. So this patient needs workup, further workup. I would just like to tell a few more points about when to image, or rather the absolute must indications for imaging in case of any cranial nerve palsy for that matter. One indication is a young patient. Second thing is a recurrent cranial nerve palsy. Third is a bilateral cranial nerve palsy. Even though you have a 70-year-old uncontrolled diabetic with pupil sparing third nerve palsy, but it is bilateral, image this patient. Okay. Even though you know it that it is ischemic, deep down somewhere your gut is telling you ischemic, but still image it, because if it is a bilateral presentation or a recurrent presentation or a young individual with cranial nerve palsy, these are unusual cases. Another important thing that we have to ask in the history is any history of HZO. HZO again can cause cranial nerve palsies or orbital apex, or it can cause even cavernous sinus involvement. So HZO is another notorious bug that we have to keep in mind, because we all know it stays dormant in the ganglions and then it becomes it reactivates to cause post-herpetic neuralgia and all those conditions. So post HZO also third nerve palsy can be encountered. So that is another thing in our history that we have to ask for: fever with rashes and any vesicular eruptions on the body. Yes, definitely. It can cause. In fact, seventh nerve is more commoner than third nerve. Third nerve is not that common. Seventh nerve is more common. So at a resident level, or if such a case comes to you at in your examination, that is another important, because this definitely a third nerve palsy can come as a long case in your final MS or DNB or DO paper, whatever exam, whatever you are doing. So your discussion will mainly go on investigative modalities, history, examination. Examination, they may not ask that much, but investigative modalities and history, definitely they will go deeper into. Third thing is management. Okay, so when do you suppose if this is a cranial nerve palsy that is non-resolving? Okay, when do you call it as a non-resolving palsy? When will you want to operate this patient? And what are the rather the changes what you are expecting? Okay, forget that. When will you want to operate this patient, and when will you call this as a non-resolving palsy? 6 months to 1 year is too much. Yeah, maybe around 2 to 3 months is yes. You can call it as a non-resolving palsy in that time. But before intervening, it is a must that you wait for at least 6 months. In any acute condition, you have to wait for at least a period of 6 months before trying any intervention. Correct. Operate after 6 months. Generally, traumatic third nerve palsy is the only third nerve palsy that requires any surgery. If it is ischemic, usually it self-resolves on its own. So that should not be the problem. Or even if it is an inflammatory cause, it resolves on its own. Or if steroids, they definitely improve. So the treatment mainly is medical. But in traumatic third nerve palsies, you have to operate the patient. But again, you wait for a period of 6 months. Prisms unlikely because third nerve palsies will give large deviations. You can't give a prism in that situation. Ischemic case, 4 to 8 weeks, generally they start improving, completely resolve in 12 to 16 weeks. So Botox is something that I have tried, but again, it does not generally work in third nerve palsies. It works beautifully in sixth nerve palsies. So Botox is something that you can try for temporary, but it will worsen the ptosis, that's all. So I don't really advise Botox to third nerve palsy patients. Usually the cause is known. In young patients, you will definitely find a cause. It will be very rare that you don't get a cause. If everything is negative or you're not getting any cause, okay, it is even worth to give a therapeutic trial for myasthenia. You can try it for a month. That also you can do, because one of the patients I remember who had a similar presentation, who had come to me, he was a 28-year-old male. I got him imaged, I did everything. Yeah, ptosis worsening will reduce with diplopia. Yes, definitely. You don't have to give any monocular occlusion or anything. Fresnel prism, again, no, not really. I mean, patients are not that comfortable with it. First of all, it is very expensive. And patients are not that comfortable in my experience. That is what I have seen. So better not to do anything. If the ptosis is there, it will just help him anyway relieve the diplopia. Any other questions you all have or you want to ask?
Yeah, Dr. Vishwesh, what is the role of oral steroids, do you feel, in such cases?
Oral steroids, generally, if it is an inflammatory condition, it will improve. Like I told you, I had a case of ophthalmoplegic migraine, which was something that I diagnosed out of elimination. I mean, I didn't know that ophthalmoplegic migraine can cause a cranial nerve palsy. So that is something I dug up literature, and the only thing that that patient had was his ESR was high. That's all. There's nothing else. So I gave him a trial of steroids. So he did improve with steroids, and I kept monitoring the ESR levels also. So he did improve with that. So yes, you can definitely give a therapeutic trial of steroids if there is no other contraindication. In an acute setting, yes, you can give.
Because
Somebody,
generally, if we refer these cases, or they come from the neurologist or the physicians or even the ENT, they would be started on oral steroids.
right.
So
That makes our job little more difficult in that case, because
Yeah.
we have a half-treated patient, so we don't know where to start. And the worst is if the patient has already had a plain MRI, so you don't know what to do next, whether to re-image or no. But if your patient is affording, definitely re-image. Okay, if cost is an issue, then yes, you can maybe wait. If there is no obvious IXOL on that plain imaging, you can wait for some time, but you have to keep the patient on close follow-ups. Then at least see the patient once in 10 days.
Right.
That is something that I would advise.
Because this patient, again, we had done a CT scan first, because that was available at low cost in
Right.
medical college. And then definitely that showed an enlarged cavernous sinus. So then we went with MRI, which was absolutely normal. And then later on, the patient started complaining that he has difficulty in swallowing. And
Okay.
so we checked everything for facial nerve. It was fine. So then we referred to a neurologist if it is like multiple symptoms of cranial nerve palsies are there, whether it can be a part of a MS spectrum or whatever it is. But everything else was fine in this. And
Sir, what about ice pack and this thing, fatigue test? Because
uh,
difficulty in swallowing, again, my thought process would go more towards myasthenia only.
okay, but it is still there to the patient, and it is not which comes and goes. We have not done an ice pack test because
Okay, okay.
actually that it didn't strike that, because it looked
Right,
like
right.
a blank third nerve which no waxing, waning, and so yes, maybe when the patient comes next, the ice pack test would be.
You can do an ice pack test. You
Symptomatically, he
can,
has improved now. His
okay.
diplopia is now less over a period of.
Did they start on steroids?
Yes.
The myasthenia will also improve with steroids.
Yes. So now it is again an open bag.
No, you can give him a therapeutic trial with just pyridostigmine.
Okay.
You cut off the steroids completely, just give him pyridostigmine, call him after a month. If he's comfortable and he's improving, it's unless proved otherwise, it's myasthenia.
Okay.
Because right now, even getting anti-ACH or anti-MuSK will not be of any use because the steroids will have suppressed it now.
Right.
So that is how we can do that. We can call him for follow-up and you can give him a trial of just pyridostigmine Gravitor 60 mg thrice a day. You can give him. So
Yeah,
and you can just see him after a month.
Sir, can't we do pyridostigmine, neostigmine test now?
You can
if
do.
we have started the steroids?
You can do. Definitely you can do. But most of the places, like in the previous 2 hospitals where I used to work, we didn't have access to neostigmine test that easily. So if you have access, go ahead, you can do it. If you don't have, then you can.
And one more question, sir. In case of it is a pupil involving third nerve palsy, how important is angiography, CT or MRI angiography?
That is the most important thing to do in that case. Then you don't have to look left, you don't have to look right. Straight away send a patient for MRA. Because that is a life-threatening condition. Aneurysm of the PCA. So that is something that is the first thing that you are supposed to do, and send the patient to an interventional radiologist. They'll take care.
So yeah. If MRI is done, do we still send the patient for CT angiography?
If it's pupil involving, yes. No questions asked. Okay. You have to send.
No, not CT. You will ask to do an MRA angiography.
MRA is better, but if again cost is a problem, then CT angio is okay.
Yeah.
MRA ideally better.
Okay, so thank you.
And sometimes you can just ask the radiologist, because for MRA, they don't have to do any special procedure. So if he is like in your medical college or you know him, so you can just put in a message that to just look for an aneurysm, and he may not charge extra to the patient, and you can get that done. Because it is just in the slice, it's just another program for them. It is seen to them.
Right. Absolutely, doctor. Somebody asked a question. What do you do in case of a child with ptosis to avoid amblyopia? Okay, child with ptosis is something that you have to be very careful. First, see how much is the ptosis, whether it is involving the pupillary axis or no. Your half the problems will be solved if it's not involving the pupillary axis. But if it is involving the pupillary axis, you have to see what type of ptosis that is, whether it is an aponeurotic ptosis, myogenic, neurogenic, whatever it is. Most important, rule out an MED. If it is a congenital ptosis, rule out an MED, monoocular elevation deficit. That is something that you have to rule out, because you cannot do a ptosis surgery without ruling out an MED. It will change everything. Okay. If it is a pure congenital ptosis, definitely our oculoplasty colleagues will help us. They can plan depending on the other parameters like LPSA and other factors. You can plan a ptosis surgery. Crutch glasses, I don't think a child will wear it. Better to plan it temporarily. Yes, you can give for some time, but better to plan a surgery. The definitive treatment is surgery. But of course, you have to rule out MED. That is something that you have to do. And congenital myasthenia also can be there. So those a ptosis evaluation, complete ptosis evaluation will be required for that case.
In a case of third nerve palsy with child with ptosis, uh, there is the risk of amblyopia development is also there.
Definitely, there is a
So
risk.
what will you do if can you wait for 6 months or advise any treatment?
See,
or
congenital
anything?
third nerve palsy is a very tricky and a difficult situation for any strabismus surgeon. Okay. So it is one of the most difficult things to manage in strabismus. It is tougher than Duane's and whatever other Brown and everything. So congenital third nerve palsy, if pupil is involved, you have to, what I generally do is I image the patient. I see whether there is an absence of the third nerve, whether there is a hypoplasia of the third nerve, and what is the bulk of the extraocular muscles. That is another thing that I see, whether there is a severe thinning of the IR, SR, and MR. That is something that I see. Then the second decision is you have to operate this child. Okay. Generally, what I do, if the FDT is full and free, then I have even done a LR to MR transposition and seal. But no matter what you do, XT always remains. So get the XT as close as possible and then plan a ptosis surgery. That's all you can do. But amblyopia definitely is there in congenital third nerve palsy. You can try to reduce the degree of amblyopia by doing a faster surgery. But yes, definitely between the strabismus and the ptosis also, you have to wait 3 to 4 months. You can't do it immediately. So amblyopia does set in to some extent. So, but the go-to procedure will be get an imaging done. Look for the bulk of the ocular muscles. Okay, look at the thickness, and the surgery will have to be planned. Either a periosteal fixation, that is the ultimate thing that we do. But yeah, something will have to be done in a child with third nerve palsy.
Dr. Vishesh, Chinmay here. Can you
Anyone,
hear me?
any other doubt? Anyone want to discuss anything regarding this
Dr.
case or-
Vishesh?
Yeah, go ahead, Chinmay.
Yeah, so in long-standing cases where you have an aberrant regeneration, does your surgical plan change, or
Yes, it does. So
how does it change?
first of all, aberrant regeneration will come only in a congenital case or a traumatic case. It will not be seen in any other type of third nerve palsy. So if you have an aberrant regeneration, so definitely you can do something which is a differential recession. Okay, that is you recess the better eye more. Okay, so or you call it something, we call it as a fixation duress. Okay, so what we are basically doing is we are weakening the other eye LR or the better eye LR we are weakening, so that the patient has to use more force to abduct the better eye, or to bring the better eye into primary position. He has to use more force. That will again cause adduction of the affected eye, and adduction of the affected eye will cause opening of the eyelid or improvement in the ptosis. So with one stone you are hitting two birds. You are correcting the squint also as well as improving the ptosis also. But that is only in aberrant regeneration, no other cases. Where the adduction is reasonably okay, that is fixation duress. That is something that we can do.
Okay.
Sir, if the patient is diabetic, how will the treatment change? Because can we still give steroids?
No. See, then it becomes an ischemic cranial palsy, no? So there's no role of steroids. You control the sugars, he'll be fine. In a span of 8 to 12 weeks, he'll be fine. You just control the sugars. But keep observing the patient every week, every month, at least once a month, you have to observe the patient, whether he is deteriorating or no. Whole point is, see, even if the recovery is slow, it's okay. He should not deteriorate. That is important. he or she. If again diabetic, better get an HbA1c also. That will give you a better picture. Okay, maybe fasting post-meal may not give you a clearer picture. Get an HbA1c in that situation and get a urine routine microscopy. These are two things that will help you. And of course, your fundus examination, which you will be doing, that will give you a clearer or better idea of the long-term control of the diabetes. So that will give you some hints. The patient has DR, patient has HbA1c of 8, 9. That is clear-cut indication that it is an ischemic cranial nerve palsy.
Yes.
But yeah, HbA1c, urine, and a detailed fundus examination to rule out any DR changes. These three things have to be done.
I think third nerve is clear to all. So if any more doubts anyone is having, because we have sir with us for some more time, so you can rapid fire some
I
more
would like
doubts.
to add one more point, Dr. Anuj. The
Yeah.
course of third cranial nerve should be absolutely clear in your head. Okay, there are some good pictures or some good schematic diagrams that are there on the internet. You can go through them. So the course of the third nerve should be absolutely clear, because if you know the anatomy well, lesion localization is easier. So at the same time, you can even advise your radiologist in a much more better way that what exactly you want. If you have that clarity in your head, only then the radiologist will search for it. The radiologist has 10 things to do. I mean, like, third cranial nerve must be something that he must have read in maybe a paragraph in their textbooks. That's all. They have to do 10 things. You have to be clear of what you want from them. So that is very important. It's not that we write MRI and lift our hands. We can't do that. Okay. As far as the exam is concerned, diplopia, approach to diplopia, very important. Your viva can go in these areas: approach to diplopia, cranial nerve palsies, multiple cranial nerve palsies, and imaging and investigative modalities in cranial nerve palsies. So these are the main areas where your viva can go.
So we have one question regarding ophthalmoplegic migraine. So
Yeah, again, like I said, ophthalmoplegic migraine is a diagnosis of elimination. You can't pick it up like you can't directly pick it up. So that is something that I have seen. Patients are generally relieved with steroids. I generally refer them to a neurologist, because any other beta blockers or anything they want to start, or any prophylactic medications they want to start, it depends on, I let them take the call. That is not something that I have much experience with.
but per se, a case of headache with third nerve, you are more likely to image, even if
Yes.
pupil
In
sparing.
a young patient, definitely yes. In a young patient, recurrent nerve palsy is bilateral nerve palsy. No questions asked. You have to image these three conditions.
Sir, I want to ask, if patient is ischemic third nerve palsy, till how much time do you wait to come for complete resolution before doing anything, means for only controlling BP or sugar?
12 to 16 weeks maximum. 12 weeks at least you have to wait.
If
But
not
in
resolved
between,
within
no,
12
the
weeks,
first follow-up will be at the end of 3 to 4 weeks. In that time, you are supposed to see if your patient is improving. Even by 10%, if he improves, it's okay. You're on the right track. He should not deteriorate in that 1 week, in that 1 month time. That is more important.
if it get deteriorated, then you will do the
Imaging.
MRI or anything.
Imaging, yes.
After that, you wait for only 1 month.
Yeah. 1 month is more than enough. Basically, you want to rule out whether the cavernous sinus is involved or no. All those things you want to rule out. Now, my senior or my mentor, Dr. Virender, who taught me neuro-ophthalmology, he images all cranial nerve palsies. That is his protocol.
Yeah.
So, yeah, but I generally don't. If it's a clear-cut ischemic palsy, I wait. I don't image. But each to his own.
So if you're not imaging, do you follow up for pupil
Yes,
on a
3
regular
weeks.
basis?
3 weeks I follow up the patient after. 21 days I call the patient after. If there is slight improvement, wait for another 3 to 4 weeks. If there is deterioration, immediately image. Always a good habit to take photographs of the 9 gaze. That is another thing. Nowadays there are apps available, 9 gaze and all that. Better have good habit to document, because someone may write -2, someone may write -3. That is a very subjective thing, and you may not remember what you have seen 2-3 weeks back. If you have a busy clinic, you may not remember how much exactly was the limitation in the motility. So better thing, you take a photograph in your mobile phone, refer it. That is an easier way to do it. That is something that I follow. So these are some tips that you can use in your practice.
So any closing remark, sir, or any other point you would like to stress?
Not really. See, cranial nerve palsy is complete. All 12 cranial nerves have to be checked. Neurological examination has to be done. Just grossly, it has to be done. These are two important, very important things. His trauma has to be ruled out. Keep at the back of your mind, keep myasthenia as a DD. Myasthenia is a hidden thing. Generally, we don't. I have also missed many, to be honest, in my fellowship days. But that is something that I have learned by burning my own hands. So yes, you definitely learn. Every patient teaches you something or the other. Learn from your patients. Keep an open mind. So yeah, these are the few things that you have to do. That is important. And use imaging judiciously. Don't image randomly. Write the appropriate imaging techniques and be clear in your head what you want from the radiologist. That is important.
So I think we will close down then. So it was a very nice and informative session. And regarding this last point of myasthenia, is definitely, I think everyone is going to now rule out myasthenia in all their cases, because we don't want
Keep it
to.
at the back of your mind. That's all. I mean, don't. It is something that we have to develop over time.
Yeah.
It's not something that comes naturally. So yeah, that is something that we can work on.
And this was actually because the India-Pakistan match is going on, and we still crossed over 60 participants, which is amazing. And this is actually also sort of an India-Pakistan match, but a friendly one, because our presenter, Dr. Zubda, is from Pakistan, and Dr. Vishwesh is from Mumbai. So we were having a good camaraderie here, and we will join again, maybe with the case of myasthenia, and we will have Dr. Vishwesh again. So I'll thank you everyone, and especially Dr. Vishwesh, for sparing time, and thanks a lot, sir.
Thank you so much, Dr. Anuj. It was a pleasure being here. One last question. Will myasthenia likely to be bilateral? Not necessary. It will be bilateral. It can be unilateral also. More than unilateral, it's asymmetric. So yeah, it can be bilateral also. Okay, wonderful. Thank you for having me.
Okay, chalo.
Yeah.
Good night.
Good night. Location which
City?
270.